everyone. So today we are going to do one of the important joints of the upper limb, that is the shoulder joint. Now when we are doing or when we are studying about a particular joint, we should know certain things. First, what is the type of the joint? Then what are articular surfaces forming the joint? Then comes the ligaments which provide stability and support to the joints. Okay, then we should know what are the relations of the particular joint with the surrounding structures. Then we have to know about the movements which are produced by the joint along with the muscles which are producing them. And lastly is the applied anatomy of that particular joint. Okay, so these are important terms and the topics that we have to cover when we are going to study about a joint here. Now let's start with what is the type of the joint here. Now the shoulder joint is a ball and socket variety of the synovial joint. Okay. Now as we know that in general anatomy we have studied there are three types of joint. One is the fibrous one, which are either immovable or slightly movable. Then there are cartilaginous ones which are slightly movable, and the third type is the synovial joints which are freely movable. Okay, so the shoulder joint is basically one of the variety of the synovial joint, that is the ball and socket variety. Now the articular surfaces. Now what do you mean by articular surfaces? As you know, joint is basically a junction between two or more bones here. Okay, so the parts of the bones which are joining together to form that particular joint are called as the articular surfaces. So in the shoulder joint, the articular surfaces are the head of the humerus here. Okay, the head of the humerus is the part of the humerus bone which is present in the arm and which is an example of a typical long bone. Okay, then the glenoid cavity of the scapula here, which is an example of a flat bone. Now in this diagram you can see easily this is the scapula bone here, and it has a cavity on the lateral aspect which is called as a glenoid cavity, and you can see the head of the humerus which articulates with the glenoid cavity to form the shoulder joint, which is a ball and socket variety of the synovial joint. Now since you can see in the diagram here very carefully, you can see there is a bluish color structure on the articular surfaces. Now this is called as the articular cartilage. Okay, so one of the characteristic features of the synovial joint is that presence of articular cartilage around the articular surfaces. Now what is the function of the articular cartilage? Okay, as you know, when two bones are joining together to form or articulating together to form the joint, there will be friction when there is a movement of the joint. So to prevent the wear and tear of the bones, the articular surfaces, they are covered by a fibrous cartilage here. That is the main function of the fibrous or articular cartilage. Now coming to the ligaments. I have categorized the ligaments into two parts here. First is the main ligaments, which include the capsular ligament, the glenoid labrum, the coracohumeral ligament, transverse humeral ligament. So these four are the main supports of the shoulder joint. Other than this, there are two ligaments other than this that is called as the accessory ligaments. Okay, these are the coracoacromial ligament and the coracoacromial arch here. Okay, now coming to the capsular ligament. Now whenever you are writing about shoulder joint or any joint, you should explain a bit about the ligaments also, then only the question will be complete here. Now the shoulder joint's capsule. Okay, it is attached medially to the margin of the glenoid cavity beyond the glenoid labrum. Now this is a commonly asked question in Viva also. They can ask you what are the extension or what are the attachments of the capsule onto the shoulder joint, okay, or any other joint extending up to the bones here. Now first attachment we are going to do is on the humerus, that is the lateral attachment. Laterally it is attached to the anatomical neck of the humerus except inferiorly, where it extends downwards 1.5 centimeters or more onto the surgical neck of the humerus. This is the extension of the capsular ligament of the shoulder onto the humerus. Now onto the scapula here, how it is extending. Now it is extending medially beyond the supraglenoid tubercle, and it is enclosing one of the tendons of the biceps, which is the long head of the biceps. Why it is enclosing? Because the biceps brachii muscle, which has two heads, that is a long head and a short head. Out of this, the long head arises from the supraglenoid tubercle of the scapula. Okay, so what is the supraglenoid tubercle? Now on the supraglenoid tubercle, on the glenoid cavity here, there is a tubercle above and below. Above tubercle is called as supraglenoid tubercle, which gives attachment to the long head of biceps, and inferiorly also below the glenoid cavity there is a tubercle that is called as the infraglenoid tubercle, which provides attachment to the triceps muscle, the long head. Okay, now coming to the capsular ligament continuation here, it is the least supported inferiorly, where dislocations are very common. Now please remember, the capsular ligament covers and provides support to the shoulder joint, but it is least supported inferiorly, and because of this least support, dislocations of the shoulder joint are much more common in the inferior aspect, and they can damage the axillary nerve, which is related to the surgical neck of the humerus. So please remember, whenever somebody asks you where is the common dislocation part of the shoulder, it is mainly inferior aspect of the shoulder. Now superiorly, it is deficient for the passage of the tendon of the long head of the bicep. So this is a characteristic features of the capsule. One more time we can do it. First, we can do it the attachment on the humerus. So laterally it is attached to the anatomical neck of the humerus, except inferiorly, where it extends downwards 1.5 centimeters or more onto the surgical neck of the humerus. Medially, it extends beyond the supraglenoid tubercle, from which the long head of biceps is originating. Okay, that is why there is a deficiency or a small opening superiorly in the capsule, so that the tendon of the long head of biceps can pass through it. Okay, now inferiorly, the capsule is least supported here, due to which the dislocations of the shoulder joint are much more common on the inferior aspect, and such dislocations can lead to the injury to the axillary nerve, which is related to the surgical neck of the humerus here. Okay, now coming to the next, these are all main ligament. First is the capsular ligament. Now the second ligament is the coracohumeral ligament. Please understand this, whenever the name comes, please try to get some answers from it itself. Okay, that is here I can divide this ligament into two names, that is coraco and humeral. That means the coracoid process and the humerus. It will be extending between the coracoid process and the humerus bone here. Okay, so it is extending from the root of the coracoid process of the scapula to the neck of the humerus, which lies opposite to the greater tubercle. Now in this focus diagram, you can see there is the coracoid process here, that is the hook shaped process of the scapula. So the coracohumeral ligament extends from the tip of the coracoid process up to the neck of the humerus, just opposite to the greater tubercle here. Okay, this is the extension of the coracohumeral ligament. Now coming to the next ligament, that is the transverse humerus or transverse humeral ligament. Now in this, what happens? Please remember, when we are studying the humerus bone, there are two tubercles in the humerus bone, a greater tubercle and a lesser tubercle. Now between the greater and the lesser tubercle, there is a depression which is called as intertubercular sulcus. Another name is bicipital groove. Okay, now this bicipital groove here is basically a depression between the two tubercles. Now a ligament bridges over this bicipital groove or intertubercular sulcus, and the name of this ligament is transverse humeral ligament. Okay, now please remember, as I have told you, the tendon of the long head of the bicep arises from the supraglenoid tubercle. It goes down and passes through the bicipital groove here. Okay, so it lies beneath the transverse ligament here. So the tendon of the long head of biceps passes deep to this ligament. Now coming to the glenoid labrum. Now as we know, the head of the humerus is larger as compared to the glenoid cavity of the scapula. Okay, so to make the cavity more deep so that the head of the humerus can fit into it, there is a development of a fibrocartilaginous rim which covers the margin of the glenoid cavity, and this is called as the glenoid labrum. The glenoid labrum helps in deepening the cavity so that the head of the humerus can fit into it perfectly. Okay, then I have told you there are two accessory ligaments. They are called as coracoacromial ligament and the coracoacromial arch. Now again I am telling you this, since the name, please see the name carefully so that it is easier for you to understand where is the extension or attachment of the ligament. Since the name is coracoacromial ligament, that means it extends between the coracoid process and the acromion process of the scapula. Okay, and it is providing the stability of the superior aspect of the joint here. Okay, now the coracoacromial arch is the second support of the shoulder joint here. The coracoacromial arch is basically formed by the coracoid process, the acromion process, and the coracoacromial ligament. Here the diagram, in this diagram you can easily see the coracoacromial ligament which extends from the coracoid process to the acromion process. Now in this diagram on this side you can see, if I focus it, you can see there is a arch which is forming between the acromion process and the coracoid process of the scapula, and this arch is called as the coracoacromial arch. So the coracoacromial arch is formed by the coracoid process, the acromion process, and the coracoacromial ligament. Okay, so these are the accessory ligaments of the shoulder joint. So we are dividing the ligaments of the shoulder joint into two parts. One are the main ligaments, second is the accessory ligaments. Now coming to the bursas related to the joint. You should know the names of the bursas which are related to the shoulder joint. Now what do you mean by a bursa? A bursa is a fluid filled extension of the synovial cavity, and it is a bag-like structure. It is present between the bones to prevent the friction between the bones here. That is the main function of the bursa, and it produces a cushioning effect and prevents friction between the two bones. Okay, so the main bursas of the shoulder joint includes subacromial bursa, subscapular bursa, and the infraspinatus bursa here. Okay, so these are the important bursas which are related to the shoulder joint. Now coming to the relations of the shoulder joint. Okay, now I always advise students to study the diagram very carefully and try to practice the diagram thoroughly, because it will be easier for you to understand and write down the theoretical part. That is why here I have added the diagram along with the theoretical part. So if a question comes on the shoulder joint and when we are writing about the relations of the shoulder joint, please draw this diagram and explain it, because in anatomy diagrams are very important, and if you draw the diagrams it carries some extra marks. Okay, so coming to the relations, first relation we are going to do are the superior relations. Okay, please see the diagram along with the theoretical part so that it is easy for you guys to understand. So superiorly you can see there is a coracoacromial arch, okay, formed by this coracoacromial ligament, coracoid process, and the acromion process of the scapula. Now the second is the subacromial bursa, which is just below it. Then there is the supraspinatus muscle and the deltoid muscle. Okay, that is the superior relations of the shoulder joint. Now coming to the inferior aspect, you can see on the inferior aspect only one structure is related to the shoulder joint, that is the long head of triceps. The long head of triceps arises from the infraglenoid tubercle of the glenoid cavity. I am mentioning it continuously because that is why it is related to the shoulder joint. Now when we go to anteriorly the structures which are related to the shoulder joint are subscapularis, coracobrachialis, and biceps short head and the deltoid anterior fiber. So when we study anterior relations, first you can say the anteriorly are subscapularis, that is the muscle which is present in the subscapular fossa. Then there is coracobrachialis, then short head of biceps, and the deltoid muscles, that is the anterior fibers of the deltoid muscle. These are the anterior relations of the shoulder joint. Then coming to the posterior relations, posteriorly you can see there is deltoid, posterior fibers of the deltoid, there is infraspinatus and the teres minor. So these are the posterior relations of the shoulder joint. Now the structure which lies within the capsule is this, I have already told you in the starting, that is the long head of biceps which arises from the supraglenoid tubercle of the glenoid cavity. So this is what you have to write about the relations of the shoulder joint, and please draw this diagram, then only the relations of the shoulder joint will be complete. Okay, now coming to the blood supply of the shoulder joint. Please, for this just you have to know what is the main arteries which are supplying blood to the particular part. So the first is the anterior circumference humeral artery, then posterior circumflex humeral artery, suprascapular artery, and the subscapular arteries are the main arteries which supply blood to the shoulder joint. Now coming to the nerve supply. Okay, nerve supply includes axillary nerve, musculocutaneous nerve, and the suprascapular nerve. These are the nerve supply and blood supply of the shoulder joint. Okay, now coming to the movements. Look, movements of the joints are very important. The movements which are produced in the shoulder joint are flexion, extension, abduction, adduction, medial and lateral rotation, and one more motion, that is circumduction. You know that is flexion is decrease in the angle, extension is increase in the angle. Abduction basically means movement of the whole arm or the shoulder away from the body. Adduction means movement towards the body. There is medial and lateral rotation, and circumduction motion is a rotatory motion which you can easily see in sports person like the bowlers. The bowlers are doing the motion, rounded motion, when they are throwing a ball. That movement is called as circumduction. Okay, so it consists of 6 main movements: flexion, extension, abduction, adduction, medial and lateral rotations, and the circumductions. Okay, so this is how you have to write some movements. Then you have to advise and say what are the muscles which are producing the movements of the shoulder joint. Okay, shoulder joint is not moving with the help of the bones here. Okay, the movements are produced with the help of the muscles which are present on the surroundings of the shoulder joint. So first movement is flexion here. The main muscle which produces the flexion is the pectoralis major muscle, which is the muscle of the anterior part or the pectoral region muscle. It has 2 heads, a clavicular head and a sternocostal head. Out of that, the flexion is caused by the pectoralis major clavicular part. Then flexion is also caused by or produced by the deltoid anterior fiber. Please remember, deltoid is a large muscle here which provides shape to the shoulder, or we say contour to the shoulder. It has 3 fibers: anterior, middle and posterior. So if I am mentioning anterior fibers, that means it will present on the anterior aspect here. Okay. Accessory muscles which produce flexion are coracobrachialis and the short head of the biceps. Okay. Then coming to the extension of the shoulder joint. Now extension is produced by the deltoid posterior fibers. One more muscle at the back, that is the latissimus dorsi. The accessory muscles include teres major, triceps long head, and pectoralis major sternocostal head. Now coming to the adduction. Adduction means movement of the shoulder towards the body. Below is the diagram showing the flexion, extension, abduction, adduction, medial and lateral rotation. So adduction is caused by pectoralis major, okay, then latissimus dorsi, long head of biceps and the short head of the triceps, okay. Now accessory muscles include teres major and the coracobrachialis. Then comes abduction. Please remember, abduction of shoulder joint is a very important question. It comes as a short note also, and it is frequently asked viva question, okay, whether it is BPT, dental or anything. Abduction, they will ask you up to what degree particular muscles are causing. So you should know the degrees up to which abduction is occurring and what muscles are producing the action. So abduction, please remember and hear it very carefully. Abduction is movement of the shoulder joint away from the body. So from 0 to 15 degree of abduction is produced by the supraspinatus muscle, okay. Then from 15 degree to 90 degree of abduction is done with the help of deltoid. Then from 90 to 180 degree of abduction, that is overhead abduction, is produced by the serratus anterior along with the trapezius muscle, okay. So these two muscles produce overhead abduction. Now why it is important? It is important to know why and what muscles are producing that particular action, because please remember, these all muscles, they have a particular nerve supply. Now what happens, due to certain injuries, the nerves can get injured. Now when a particular nerve is injured, then what happens, the muscle it is supplying is paralyzed. So there is the restriction of the movement occurs when the muscle is paralyzed. So if you should know, that is why in this that is mentioned here, what up to what degree which muscle is producing abduction, okay. Now medial rotation is produced by pectoralis major, deltoid fibers anterior, latissimus dorsi and the teres major. Accessory muscle includes subscapularis. Lateral rotation is brought about by the deltoid posterior fibers, infraspinatus and the teres minor here, okay. Now this is how the flexion, abduction, extension, medial and lateral rotations are occurring. Now coming to the very important topic, that is the abduction of shoulder joint. I have told you this is very important and it is a frequently asked short note question also. Now the abduction occurs up to 180 degrees. The movement takes place partially at the shoulder joint and partially at the shoulder girdle. Now the humerus and the scapula, they are moving in a 2:1 ratio during abduction. That is how we are going to explain it like that. In 15 degree of elevation of the shoulder, 10 degree occurs at the shoulder joint and 5 degree are due to the movements of the scapula here, okay. Now the articular surface of the head of the humerus, which is fitted against a glenoid cavity, can cause or allow abduction only up to 90 degrees. Please remember this point very carefully. Now up to 0 to 15 degrees supraspinatus is helping here during abduction. From 15 to 90 degree deltoid is causing the abduction. Now since the humerus is articulating with the glenoid cavity, it permits abduction up to 90 degree only. Now when it reaches its limit, that is up to 90 degree, to do overhead abduction, that is up to 180 degree, there should be the lateral rotation of the head of the humerus. Okay? When it laterally rotates, it comes to lie deep to the coracoacromial arch, which is the accessory support of the shoulder joint. Now the abduction is initiated by the supraspinatus, but the deltoid is the main abductor. Deltoid muscle is a major muscle of the shoulder joint. Now the scapula is rotated by the combined action of the serratus anterior and trapezius, and it helps in overhead abduction. Okay, so this is about the abduction. When you are done with what is the process of abduction, then in the last of completion of the short note, you should write what muscles are causing abductions up to what degree. So the abduction of the shoulder is initiated by the supraspinatus, that is 0 to 15 degree. Deltoid muscle can abduct to 90 degree, that is it is a major abductor from 15 to 90 degree. When it reaches 90 degree, there is lateral rotation of the humerus. Then trapezius and serratus anterior help in the elevation of the shoulder joint up to 180 degree. So this is about the shoulder abduction or abduction of the shoulder joint. So I have already told you a question is only complete when you done with the clinical correlation or the applied anatomy. So one of the applied anatomy of the shoulder joint is dislocation of the shoulder joint. It is a very common inferiorly happening point, that is, I have told you the capsule is least supported inferiorly. Because of this, the shoulder dislocation is common inferiorly, due to which the axillary nerve gets injured because it is related to the surgical neck of the humerus. Even though it is an inferior dislocation, when we are doing the clinical aspect, it is described as an anterior or posterior dislocation. Please be very clear. So if a doctor says it is an anterior or a posterior dislocation, he mainly means it is an inferior dislocation of the shoulder joint. Okay, now coming to the clinical correlation second, that is frozen shoulder, which is a very common condition which is seen in persons aging up to 40 to 60 years of age. It is a clinical condition which is characterized and by pain, and there is uniform limitation of all the movements of the shoulder joint. Okay, it occurs due to the shrinkage of the capsule with age, and it is also called as adhesive capsulitis. Okay? Adhesive capsulitis basically means the capsule is becoming adherent to the articular surfaces. Okay, and it is mostly common in persons having age of about 40 to 60 years of age. The second is a rotator cuff disorder. Rotator cuff basically also includes one more condition, that is calcific supraspinatus tendinitis. Okay, so the rotator cuff is commonly injured during repetitive use of the upper limb above the horizontal level. Okay, like the sports persons they are doing, for example bowling and all. Okay, so there will be deposition of calcium in the supraspinatus tendon is a very common condition. Due to this calcium deposit, it irritates the overlying subacromial bursa, which results in subacromial bursitis. That means inflammation of the bursa. Bursitis, itis, wherever it is coming, it means inflammation. The pain occurs especially during 60 to 120 degree of abduction. It is commonly seen in males over the age of 50 years. So clinical correlation, three main things you have to remember: dislocation of the shoulder, where it is much more common, frozen shoulder, and the rotator cuff disorders. Okay, so these are the main points that you have to cover when you are studying a joint. So shoulder joint is one of the important joints, and it can be asked as a long question. Enumerate question can come from this shoulder joint. Enumerate the ligaments of the shoulder joint, enumerate the movements of the shoulder joint along with the muscles producing them. Okay, abduction can be asked as a short note itself. Okay, sometimes they can ask you clinical importance or what are anatomical basis of frozen shoulder, dislocation of shoulder, rotator cuff disorders. So many questions can be covered within this particular one topic. Okay, I hope you have understood the shoulder joint very clearly, and thank you for your time. See you for the next class later on. Thank you.